Hi, we are here at Dante Pazzanesi again, just to review the case we did last week. And I think it's very important to summarize what we have done, since it was a very complex case, and I understand it's very important to have Dimitri summarize the case at the beginning.
Thank you, Fausto. Just to remind you, this is a young 48-year-old female patient with severe stenotic mitral bioprosthesis dysfunction, plus severe TR, plus suprasystemic pulmonary hypertension with a systolic pressure around 120 millimeters per mercury, who was deemed too high risk for surgery by our heart team. We decided to proceed with transeptal mitral valve-in-valve replacement. And like Fausto just said, during the procedure we faced some challenges to perform transeptal puncture due to huge left atrium and some interaction with pacemaker leads. And the first puncture site was not ideal, as you can see here. Maybe the puncture was too low and too anterior. And we struggled to first cross the valve with a pigtail, not only because of leaflets calcification, but also due to bad angulation. And after positioning of extra stiff confident wire in the apex of the left ventricle, we performed a septostomy with a 14 millimeters balloon, but we failed to cross the septum with SAPIEN 3. So at this point, we decided to perform another puncture. The valve was reintegrated into the sheath and removed, which is usually easy with the SAPIEN 3 bioprosthesis. And the second puncture was done more posterior, but again, it was not possible to cross the thickened septum, even with the use of a bud wire in the left atrium, as you can see here.
Dimitri, I know it was a very hard puncture. We did the first one, and after we did a second attempt to cross the septum with the SAPIEN 3 valve, and we failed, and now it's hard. I need to ask you, what to do the next?
So we discussed some other techniques. So in addition to buddy wire, to use a buddy balloon across the septum is a possibility. Another one is to cross the aortic valve to snare a long stiff wire in the descending aorta and create AV rail, or even to put a long, bigger sheath, dry seal 26 French in the left atrium, like we do for transcatheter pulmonic valve replacement, for example. But unfortunately, we lost wire position and the transeptal access at that moment. So we did a third puncture, now more posterior and more superior. And as you can see here, the left atrium was enlarged. And then we predilate with a 16 millimeters non-compliant balloon, and we used a stiffer wire, a Lundequist wire, in the left ventricle, as you can see here. Although we tend to avoid predilation of a surgical bioprosthesis because of the risk of fracture and embolization of calcified leaflets, our procedure was already too long and the patient was not completely stable. So we proceeded with predilation with an undersized balloon, as you can see on the left. And again, crossing the septum was not easy. Once the new valve was advanced into the right atrium, we tried some flexion, combined with rotation to orientate the SAPIEN 3 towards the septum. At this point, tactile feedback is important. And we felt some resistance, but we didn't push hard. We tried different orientations and gentle manipulations of the delivery system. And the solution here was to unlock the commander system and pull the pusher back while maintaining the THV in place, like we used to do just before valve deployment. And this maneuver, as you can see, facilitated the positioning of the SAPIEN 3 through the old valve, as you can see on the right video. And then we positioned the SAPIEN 3 according to fluoroscopic markers of the old valve. We deployed under rapid pacing at 150 beats per minute using wire pacing from the Lundequist wire. This was done with a very slow inflation to allow for some adjustment and with a good coordination between operators. On TEE, valve position was okay, but there was some pinwheeling of the leaflets. So we decided for further dilation with 2 cc more in the deflator, extra 5 cc in total. And at the end, we got a good result, good valve expansion with a mean gradient of 2 millimeters per mercury.
Wow, it was really hard. Fortunately, we could get the valve in place. It's successful. We are so happy with this. And now we have some problems to solve. Is it necessary to close the atrial septal defect that we provoke after transseptal procedure, Dimitri? We did 3.
Yeah. Well, regarding ASD, we think that it should not be routinely closed unless in those cases that in the end of the procedure there is a right to left shunt with hypoxemia. And in our case, there was a bidirectional shunt despite significant pulmonary hypertension and tricuspid regurgitation.
Now at the end of the procedure, I hope everyone could understand all the difficulties we had in this case. It's very hard to finish the procedure. We need to do 3 punctions. We need to implant the SAPIEN 3 and the mitral valve and prosthesis over this prosthesis, and we got a good result. We saw what we did with the atrial septal defect, and hopefully this patient goes well. And see you next time.
Great. Thank you again. Now we are back. So after this very interesting case last week, the real case in the mitral valve, I mean the valve involving mitral valve. It was a spectacular case. Dimitri was so calm to get across after 3 punctures in the atrial septal. So
yes, it was a tough case.
It was very tough.
But
now
we have another one, Paul.
Okay, I know that. But now we need to forget that one. That's our routine to concentrate. We need to be very well concentrated in the next one. And now we have another very interesting case. You need to pay attention to forget everything that you get successful behind us. And now we need to go ahead. We have here, as I was trying to present to you, Alberto Cervoni, who's going to be the first operator, one of the staff doctors here from our cath lab. And also I have Michele, who is, I was telling you, she's our 50-year fellow in the structural heart disease. And Dimitri, as I mentioned to you, is our director in the structural heart disease. So what do we have now?
Yeah, let's present the case, Fausto.
Okay.
We have the first slide, please. So our case for today is a 83-year-old female, a small lady, 54 kilos, non-frail, independent, who presented to our hospital with spinea, class 3. She has no relevant comorbidities, only hypertension. And the surgical risk scores, as you can see, their score 2 is 2.1, and the STS score is 2.3. So she's a low-risk patient for surgery. These are the lab tests and chest X-ray. Unremarkable findings. Renal function is normal. On EKG, you can see sinus rhythm, no conduction disturbance. And on echo, the LV function is well preserved. 64 is the ejection fraction. The valve, the aortic valve is severely calcified. The mean gradient is 52 millimeters per mercury, and the aortic valve area was estimated as 0.6 square centimeters. She has also a mild mitral regurgitation. So these are the CT findings. Maybe Alberto could go under our findings here.
Alberto, please.
Hey, thank you, Dr. Fausto and Dimitri. In the CT find, we have an annulus diameter from 20 and 26, an annular area of 402, an annular perimeter of 72. The Valsalva diameters are bigger than 28, so it's okay. Next slide, please. So the LVOT is 19.5 and 26.2. The sinotubular junction is 28 per 32. And the extending aorta is 39 for 41.
So there is a dilation of the ascending aorta because she's a small lady.
She's a small lady with 41 of extending aorta. Yeah. So we interrogate a bicuspid valve. It has a calcified no coronary cuspid and a calcium score of 180/58. So when we are leading with a bicuspid valve or interrogating it, we should interrogate the valve at 4 millimeters from the annulus, the intercommissural distance. So it is 27.5. It's bigger than the annulus.
Yeah, it's difficult to say if there is a bicuspid or tricuspid on the skin, right?
It's just a fusion of the.
Yeah, it seems that she has a fibrotic raphe.
So when we are thinking about the bicuspid valve, we have a difficult to choose the valve size. So we simulated different THVs in different places from the aortic root, and to choose the best valve to deploy.
Before going that, is there any evidence, strong evidence to treat bicuspid valve with it, TAVI? Can you answer this, Dimitri?
Yeah. That's a very important question. I mean, there is no randomized data yet comparing the clinical results between tricuspid and bicuspid, but we have large registry, large observational studies that shown that the clinical results in bicuspid are very good, very encouraging, with low mortality, and low PVL with the newer generation transcatheter heart valves. There's some suggestion that the stroke and the pacemaker rates
are a little bit higher
in bicuspid, but in case like that, I think it's important to.
Better. O que aconteceu, hein? Cadê o pessoal da TE? O que aconteceu, Rafael? Putz. Tá online? Okay. Can you hear us?
Yes, we can hear you clearly.
Yes, we just have a problem with the power here. We are going to continue the discussion about the bicuspid valve. Dimitri, please. Can you also see us? Okay, good. It's just in 5 minutes. We're just turning back and come back. Okay, go ahead, Dimitri.
So we are talking about the stroke and pacemaker rates in bicuspid, maybe a little bit higher. But I think it's important in patients with bicuspid aortic stenosis to be discussed at heart team, and it's very important also to look for the anatomy. I mean, if This is a really bicuspid type 1, type 0, to look for the amount of calcification and the distribution of calcification, if the raphe is calcified or not, just to decide between TAVR and surgery.
And Alberto, and we are talking about to sizing the valve. Is there any tips and trick that you can use to do that in the bicuspid valve?
As you told before, it's really important to measure the intercommissural distance. It's measured in 40 millimeters from the annulus, and you should determine which kind of bicuspid valve we are leading. We have basically 3 types of bicuspid valves. We have the tapered one, the tubular one, and the flared one. Tapered, the flare and the tubular, we do the sizing basically as the tricuspid one, based on the annulus area. But the tapered one, we should use a smaller valve.
Okay. So we have our in the part of the team. Maybe you can present the Tito and the echo and also the anesthesiology.
Yeah. So Fausto, before we move on, let's show what we did so far.
Yeah, but we need to.
So
the punction.
Yeah.
Could you please bring the camera here to the punction, just to show? Okay,
so
great.
We are going to perform this procedure under conscious sedation using a minimalist approach.
I know.
So we have puncture a radial, in fact, ulnar artery, just for hemodynamics and for pigtail.
Why did you choose ulnar artery?
She has a very small radial artery. We saw this on the ultrasound, and we decided for the ulnar puncture.
Just to measure the pressure.
Yeah, just to measure the pressure and to put a pigtail to perform the injections, to position the valve and to check the results. We did ultrasound guided puncture of the femoral artery, and we already placed a perclose. We are using just one perclose for TAVI cases. I think that performing the puncture with ultrasound is very important and allow you to use just one proglide.
I know you have a project here doing this. Alberto just presenting our big meeting here. What are your findings about this, Alberto? Using only one perclose.
As Dimitri told you before, the ultrasound guided is really important to use only one perclose, and it is safe. We have no bleeding complications, and we have less stenotic complications than using 2 perclose.
Okay, and what is the percentage you can use of the case? You can use only one proglide.
Routinely, we use only one perclose.
Yeah, okay, but in how many cases? For example, you have 100 cases, and how many we are going to use only one? 80, 90, 80%. So that's very important. The industry will love that. Yeah. We'll love that because we are going to decrease 50%.
If you need it at the end of
the income. Is that correct? The industry will love this. Okay, great.
In the end,
because everything is very expensive here in Brazil, and we need to save money. He's in the hospital, so that's the reason we are doing all this procedure and everything. We are trying to talk to them, explain to them. We pay, but we need to have a lower price to treat all patients that needed to have to need to be treated.
So in our practice, at the end of the procedure, we decided if the patient need another perclose or an angioceal.
Great.
And that's our practice.
That's great technique. So what you did more? So the pacemaker, you did a
pacemaker. This is a bicuspid, probably a bicuspid aortic valve. We're gonna predilate. It's our routine here to predilate.
In bicuspid, do you always predilate?
Yes. We tend to predilate all cases of bicuspid valves.
Why? To size the valve?
Yeah, and for this particular case, we are in doubt about sizing. And we're gonna do a predilation, and we're gonna inject some contrast during full balloon inflation, just to size the valve that we're gonna implant And I think this is an important maneuver when you are in doubt about sizing.
So this is a minimalist approach, as I
Yeah.
can see here.
Yeah.
The patient is not intubated, just a sedation with our anesthesiologist. Paulo is there? Walter. Hi, Walter. Walter is can you show the anesthesiologist? Because sometimes we just show us here, but maybe you can show the anesthesiologist just behind there. If you can see that, oh, you cannot. He's there.
So
But,
Fausto, maybe Alberto could show to you some slides about the valve that
okay.
we're gonna use.
And also we have the Tito. So can you maybe we cannot see the echo first and then go to the slides later?
Yeah, we can.
Because you did how here. So before going to the slides, okay, great. Let's Tito, maybe you can tell us what you find in the echo now in live, please.
Okay. Oh, thank you. That's the previous echo. Here we can see the parasternal long
Can you
axis
hear
view.
Tito?
Yes, we
Are you
do.
hearing?
Hear him and see
Okay,
the
good. Go ahead, please.
Okay, parasternal long axis here. We see both ventricles, the aortic valve, mitral valve. We see the increase in myocardial thickness here, a small LV, as they said before, thickening of the whole aortic valve with just a reduction of the mobility here. Just using the Doppler imaging, we have a mild regurg in the aortic side, a trace in mitral side, nothing significant. Apparently, the systolic function is preserved in both ventricle too. Just analyzing the short axis in the aortic valve, as the CCTA showed, we have the fusion of the right and left coronary sinus here, coronary leaflets, with a lot of calcifications and thickening of that. Max gradient just estimated in 84, mean gradient in 53, the area estimated in 0.6 centimeter square. Indexing for the burst surface area, we found a 0.4 centimeter square meter square. And about the function of the right and left ventricle, we cannot see any alteration of the contraction here, even in the 3, 2, or 4 chamber. Left ventricle ejection fraction is 64%. And systolic function of the right ventricle, just normal here, nothing than that.
Okay. Great, Tito. Thank you. And so you're going to show some slides?
Yes, please.
Oh, can you have the slides, please? In the same place where we left? Okay.
We are going to
Alberto.
implant.
Okay.
So I'll present the THV characteristics, the MyVal. It is a balloon expandable valve that has intermediate size as the 21.5, 24.5, and 27.5, and extra large size as 30.5 and 32, in addition of the traditional sizes of 20, 23, 26, and 29. If I can have the next slide.
Which characteristics of the MyVal can be highlighted, in your opinion? So you have a great experience with MyVal.
Yeah, if you can come back the slides, in my opinion, the fact
Could you go back to the slides, please?
Yeah. So the fact that we have the intermediate size and the extra large size is a factor that have to be highlighted. The another feature we have to highlight is that's the valve is crimped directly in the balloon.
Okay.
And it brings the possibility to retrieval the valve in case of inability to cross the annulus or another.
Do you think this is a great advantage?
In my opinion, it's a great advantage.
Okay, good. Okay.
So let's go ahead. It has a nickel cobalt alloy frame that gives a great head opacity and a radial straight. Okay, we have a PET puffing external to minimize the instance of PVL, and we have 50% of the valve is open cells. So it's good to coronary access, and as well we have a bovine pericardium leaflets that has an end calcification treatment. So can we move? So as you can see, the valve has a pattern that you can see in the screen. So we have a positioning, to position is easier. So we used to position in the second dense band. So in the base of the pigtail catheter, if you can go on. So the valve, when deployed in this position, leads to 30 to 25% in the ventricular side. The navigator, we have a high flexion system and a great flexibility. Can you go, move on? And the Python one is a 14 French expandable sheath. It is compatible with all the valves from 20 to 32. but from the 27.5, we have to pre-dilate with 18 French.
So what is your experience with MyVal so far, Alberto?
So our experience here, we have more than 150 cases since December from 2020.
Actually, was the first case in Brazil we did together here. Huh?
Yeah, we did the first case in Brazil. We have a good clinical results, low pacemaker rate, less than 1 digit, low PVL, and good hemodynamics.
So what are you doing now?
So we're gonna change the 80 French sheet for the Python.
We're gonna change the sheet now.
Yeah. As Alberto said, this is a 14 sheet.
This is a 14 sheet. Maybe you can show the hands right here, please.
The 14 French sheet.
Okay.
Go ahead.
How was the insection? So easy?
Yes. We are using a stiff wire.
Using a stiff wire.
Remove the dilator.
Okay. Doing this by, as we mentioned before, 4 hands. It's very important not to work alone.
And we also can get some hemodynamics from the side port of the sheath. Okay. So let's suture.
It's here, TJ.
And then we're gonna cross the valve.
Roberto, is there any tips and tricks to cross the valve?
The bicuspid valve is quite
which projection do you use?
We use usually the coplanar view, the same as we're using to deploy the valve. And it's quite the same by the tricuspid one.
Okay.
Yeah, this is the angel that we already did.
Okay.
Also. And as you can see, it looks like a bicuspid on the floater, right?
Yeah.
And the ascending aorta is also dilated. So
that's 41 by echo.
Yeah, she has a let's say a genotype of a bicuspid.
So you're going to use a LAO4 and cranial 10. Is that correct, Alberto?
Yes, correct.
Okay.
Thank you.
Now
So
you're bringing the
wire,
Amplatz catheter just to you have the wire direct to the valve, bringing back the stiff wire that you had, and now we have a straight wire to across the valve. Do you use echo to help you, or
No,
no,
don't. Unless we got a difficult or strange position of the wire.
Okay.
At this point,
Now you're there.
Echo doesn't help.
So the blood pressure looks okay. It's 136, 140. Now trying to have the direction exactly in the mid portion of the valve. And you saw the move you have here in the screen, exactly when you can see the open, the left just in front. Maybe if you can use, like we did the last time, this camera here, up here, just to show what you have in the screen here. I think it's important, just to show. Just to see if it's possible. Just to bring this camera here that is up of us in the big screen. Don't stress. Did you understand what I mean? Just to bring the camera to our screen here.
Okay.
Yes. Can you, this one, just move the camera to our TV monitor, please.
Let's move to RAO just to see the orientation of the.
We got across the valve now. with the stiff wire. We need to be very careful with this. That's okay. And trying to get the unplatted guide wire, unplatted catheter inside of the ventricle now. Sometimes we have hypertrophy, severe hypertrophy in this ventricle, the small cavity. And when we do that, and the guide wire can be in the wall. So that's would be dangerous. So you see, like Dimitri and Alberto did, so smooth. Now we have the implanted catheter inside of the ventricle. When I bring now wire, can you show the curve of the wire just to see what you did?
This is a regular.
Can you show
wire
here
also.
the Alberto hands, please?
This is a long regular J wire.
Oh, yeah, okay, go
Just
ahead.
to exchange the unplatted catheter
Unplatted,
for a
okay.
pigtail, and we're gonna measure the gradients
Okay.
before we proceed.
Now I have the wire inside of the ventricle now, and pulling back the unplatted guide.
Okay.
So careful and so gentle. Okay. Go ahead with the wire. You left the wire in the apex. The right position is the apex. Is correct, Dimitri?
Yes, we're gonna exchange the catheter for a pigtail.
Mm-hmm. It's easier to work with.
Yeah.
Okay.
Okay.
Now bring the unplatted catheter in the back, and now have the pigtail catheter through the wire. It's a 38 wire, this one?
No, it's 35.
35.
0.35.
135 wire.
Okay. Go ahead, Alberto.
Uh-huh. Now we have the pigtail in the aorta. We are going to cross it with the pigtail, the aortic valve. The wire is, so that's a, okay.
So it's not so easy to
No,
cross with the pigtail,
yes,
right?
with the pigtail, that's what I was mentioned. It's difficult sometimes. Now we got a better position. Go ahead, please. And go to the, great position.
So let's measure.
So the procedure starts in any details. We need to be very careful in everything. Like I mentioned in the beginning, so concentrate to have every.
Can you show us the hemodynamics, please?
Yeah.
So the gradient is about.
Oh, can you have the hemodynamics
80,
in the big
right?
screen, please? The pressure in the big screen. Can you hear me?
Yes, we can hear and see you very clearly. Thank you.
Okay, good. Can you move the hemodynamics measure to the big screen? Is that possible? And the angio, the small one? Thank you. That's great.
So now we're gonna insert a stiffer wire, pre-shaped confida. And then we're gonna check on echo just to see the orientation of the wire. It's in the apex because it seems that the pigtail is in the lateral wall, right? Let's see here.
Yeah. So do you think the pigtail was in the lateral wall?
Yeah.
Then we are gonna check with the echo. Now, can you have the echo in the screen, please?
Actually, it's on the middle part of the left ventricle.
It's not in the apex, right?
No, not on the apex.
So we're gonna try to reposition.
With the pigtail?
Yeah.
So we are trying to reposition in the apex. So the echo helped us to see it was in the lateral wall, Tito?
Yeah.
Okay.
Lateral wall.
What about now? It's better?
I think it's still, how about now, Tito? Can you see the wire?
Yeah, just a second.
It's not in the perfect
No,
position,
no,
right?
no.
Almost
so
the
we're
same
gonna-
place.
We're gonna exchange the configure wire for a regular one, just to try to be in a better position.
So the confident wire is a stiff wire. Is that correct?
Yeah.
So we are going to use a soft one. Cadê o outro? Tá aqui. We're going to change for a soft one to get a better position. So
It's here, gente.
aqui.
Ok.
Here.
Tá com guia aí?
Guarda o guia. We are keeping the confident wire. And now.
This usually happens when you cross the valve, Fausto. When you have an eccentric orifice and the straight wire
Yes.
cross maybe at the mitral beneath the papillary muscle or
some trabeculus.
yes. Let's try here. Sometimes you need to recross.
So now we are trying to position the guide wire in the apex of the left ventricle. As I mentioned before, so small cavity, hypertrophy, and we cannot get the right position, the first cross. And what Dimitri said, sometimes we need to recross again. I mean, recross, not recross again. Okay. Now is in the apex now?
Better now.
Let me see that.
Can you look at, please?
O confident
Can you show the echo and tell us, Tito?
Yeah.
Please, if you can show. If you can have the echo in the. Okay, great. Thank you. You read my
Let me insert the
mind.
confident wire, Tito, just for you to see better on echo.
Okay.
It's in the apex, Tito?
Yes, now it's almost there.
Sounds good.
Oh, it moved. No,
No?
move it to the base now. You can see here in lateral wall. Almost the same place as the other.
How about now?
Lateral wall.
Now it's better, huh?
Lateral?
Lateral wall, still in lateral wall. Yeah.
Tem que vir mais aqui, né?
Aí gira. Isso. Sozinho.
Girando pro catéter, não vai? Tá preso. Now I think you got. Can you see the wire now, Tito?
Yeah. Exactly the same place here.
Lateral wall?
Lateral wall.
So,
Infralateral.
What are you going to do?
me dá vamos de novo com o pigtail e o guia normal de novo.
Pigtail. So we are going to change again. This is a hard part of the procedure, as Dimitri said. And because of the eccentricity of the valve, we could not drive the guide wire to the place where you want. In other words, go to the
Dá o
apex.
guia normal, Michele.
Mhm.
Monta de novo aí.
Now we are bringing back the soft wire again. And try to place in the apex, as you can see here. And we are followed by echo and also by angel.
No problem.
Okay,
Let's start again.
take the amplats again, please. We are going to recross.
with the implants. Flush, please. Okay.
This patient is so small. And
Mhm.
the left ventricle is so
Yes,
hypertrophic.
yes. So when the patient is small like this, it's a young, this lady, and the left ventricle is small and also hypertrophy, make things hard.
Yeah.
But we're gonna get that. Just be calm. We cannot jump. Every phase of the procedure. And also we have here a beautiful team of nurses that is headed by Fernanda. Who is the head of nurse in the cath lab? Now we are going to recross again the valve. Look at the eccentricity of the valve. We are trying to position with the implants guide just to drive the guide wire. What I was trying to show you, if you can move with the camera that's above us to our large screen here, you're going to see the eccentricity of the valve with the contrast. Maybe it's going to be clearer. If you can do that, please. Do you understand what I mean? Bring the above of the camera, the above camera. Now it's, we got there.
Coloquem em OD.
Better, huh? Can you see the wire now, Chito?
Yes. Just 1 second.
Now it's now we have the implant catheter. Now we are going to
Maybe
change.
we can try the confident wire.
Confident wire directly.
Yeah, let's try it.
Now we are going to jump 1 step. Instead of a soft wire and go with the pigtail, we are going to do the exchange with the confident wire, with the implants in place. Being so careful, as we mentioned before, because of the small cavity of this left ventricle and also hypertrophy.
Looks better, huh?
Much better. Can you see the wire in the apex now, Tito?
Yeah.
We can see
On the
two.
apex.
We can see two.
Yeah, that's okay.
Great.
Now that's on place.
Good. Much better. See, we lost maybe 5 or 10 minutes in doing this, but we cannot place the valve, the prosthesis, with the wire in the wrong position. Don't be stressed to do this. Just have the wire in a perfect position.
So now we're gonna pre-dilate.
Okay.
We're gonna use
Balloon.
a 20 balloon.
Okay.
We are a little bit undersized. Because the minimum diameter is 20, right?
Almost 20.
And Alberto, and how can balloon predilation, you or Dimitri can answer, how can balloon predilation help into selecting the appropriate valve size?
Okay, Fausto, thank you. The predilate and the balloon size can bring us much of useful information. First, you can predict the degree of PVL with the selected balloon, which help you with the sizing, the choice of the valve. And then it can estimate the risk of the coronary obstruction as well. And we can check the behavior and the position of the balloon and the THV.
Okay. Now you have the balloon exactly in the place. Now we need to check the pace.
let's retract a little bit the balloon, Alberto, and then let's check for
How you're going to
pacemaker.
stimulate the ventricle
So marca-passo, por
through the
favor.
wire? Do you want to say?
Yeah, we're gonna perform wire pacing. So let's check. Pode ligar o marca-passo, Valtinho? 120.
120.
Okay,
May we have
looks
the
nice.
the
Pode ligar.
hemodynamics in the screen, please, just to
Pode
see
ligar.
the pacemaker.
Pode ligar.
Hemodynamics in the screen, please, the small screen.
A bomba tá pronta aí, né?
Could you please take the echo
Tá lá.
images out and place the hemodynamics, please, if it's possible?
Ok, tá bem.
Sorry
Vamos
about
ligar o
maybe.
marca-passo a 120.
Okay, good. Thank you.
Pacemaker on.
Pacemaker on. 120, 100,
180, 180. por favor.
180.
Okay, go ahead. So balloon up
So the
Inject
balloon
it.
inflation, inject. Okay,
and balloon down. Pacemaker
Stop
off.
the pacing.
okay.
So it looks like the 20, this is the 20 balloon. So it looks like it seals.
Can you make some comments what Alberto said about the advantage of
Yeah.
doing a
I think that
predilation?
we got a good ceiling with a 20 balloon.
Uh-huh.
So we're gonna use a 21.5, 21,5, por favor.
Uh-huh.
Let's show to you the angel again.
So if you were
Fausto.
using, yes.
We had a good ceiling,
Mhm.
and that's another hallmark of bicuspid valve, because the balloon is not centralized.
Mhm.
You can see that the balloon was displaced to the right
Okay.
cusp and the non-coronary cusp. So that's another feature of bicuspid valve. So patients stable.
So if you compare to a coronary dilatation like we did in the beginning and the eccentric lesions by Andreas Grunzig, usually you have the balloon could not achieve all the vessel wall in
Yeah.
all the circumference. So this is an eccentric plaques.
Yeah.
Is that correct?
Perfect.
So now we are taking the balloon out.
And we're gonna prepare the 21.5 valve.
And can you see the echo after this predilation, please? Could you bring the echo, and Tito, can you tell us your finds?
Yeah.
So the
Actually-
echo is in the screen now, okay?
Can I? Actually, we see that before we had mild regurgitation, now it's moderate to severe regurgitation in the aortic sites. And about the gradients, we see a drop in the gradients, something around max gradient around 32 and mean gradient about 19.
Okay.
So could you repeat the mean gradient, how was?
19.
19.
19.
And how it was?
No, now it was 19. the mean
19.
gradient.
How was before?
54.
54.
54. Yeah.
So with this, just predilation, we went down from 54 to 19.
Yeah.
Also, excuse me, if the camera could show the Carina crimping the valve,
yes.
I think it's.
Could you
important.
please have the crimp in the valve? Bring the camera that we have above us. Now, we need, okay. Bring it to the table. If you show us, I'll show where we are. Show me, please, and I'll show where we are. Show me, show the physicians, please, with the camera. Yes. I'm going to ask you just to bring the camera right here. Close right here. Karina, this is from the Merrill company. Can we do that by ourselves? Yes?
I don't think so.
No? So if you have an emergency, we need to call Karina.
Yeah, no, but
She's
our nurses,
crimped the valve now.
Our nurses can do that.
Oh yeah, but the nurses are learning now.
Yeah.
Our nurses, yes. So Karina is print again. So Merrill is an Indian company. They also have coronary stents they are, and also a project with, again, with bioabsorbable stents, and now they are in the valve market with this. So if you use a Sapien 3, what size would you use? A 23? It's going to be too large?
I think 23 is going to be too large. Maybe a 20
20.
with more CC on the deflator.
Okay. So this is Corina crimping.
Because we got a good ceiling with the
Okay.
20 balloon, right?
Okay. How long you're doing this? Por quanto tempo? 15 seconds, crimp the valve. So we did not get any kind of a regurgitation, Tito, by echo after predilation?
About ejection fraction or just a valve alteration?
Regurgitation. Regurg.
Yeah, it just turns from a mild
Mild.
regurgitation. Now we have a moderate to severe.
Okay, okay. Now have the valve red.
Yeah, that's one of the downsides of performing
Okay.
balloon sizing, because
Okay.
if we get
if you
get a huge aortic regurgitation,
Could you bring the camera right here, please? Right here in my hands, right here. Okay, great. Up, oh, we're almost there. Good. We are learning with this. This is a great machine. So, camera.
So valve is ready.
Yes, the valve is red now. Then Corina is bringing. Yes.
So
yeah, now if you can show the hands, our hands here, and
let's check
Alberto
the
hands.
orientation.
Yeah, Fausto, it's really important to see the valve orientation.
Could you close? Okay, great.
So it's really important to see the valve orientation. Here we have the skirt distal in the navigator, so the position is aortic position. We can move ahead, and the volume in the balloon is also important to check.
Okay. What is the volume in the balloon? 15 cc.
Okay, go ahead. The wire.
Can I go?
Yeah, go ahead.
Now the valve is going on. Go in.
Pushing.
So Alberto is take the valve. It's still inside of the sheath. Now it's showing so easily, no difficulty.
It was easy.
Okay. We still have 5 minutes to go. I think we'll have time to place the valve and check the results, and you can see that.
So we already did the deflection here.
You did the deflection?
Yeah.
We are going to
So
cross
we're
the
going to
arch,
cross
okay?
the aortic arch.
Can I?
Yeah, go ahead.
Okay, now you're gonna see this. Maybe you can have the big screen, no echo, only the angel, if it's possible. Please.
Okay, let's move to the work position.
Yeah.
Okay.
11.
Now in the hands. Can you show the hands, please? Good.
That's it.
A little bit proximal. Okay. Now, okay. The sedation, it's a little bit low level now. So, Dimitri is holding, and Alberto is going to across the valve.
I think it's a good position here. Quem tá na bomba aí?
Pena.
Just put the coplanar view, please.
It's
Now the valve, I think it's in a good
LAO4
position.
and
Can you make
Daniel
comments,
10.
or Alberto, the position of the valve, or even Dimitri?
So as you told me before, we can see the second dense band. Then we position this band in the base of the pigtail. Usually this position is okay for...
So in bicuspid and tricuspid is the same position, Dimitri?
we tend to implant the valve a little bit higher when you are treating bicuspid.
Jetta?
Yeah, I think it's a good position, right?
Okay,
A
yeah.
little bit down.
Yeah, it's okay.
Quem fica aqui?
Can I put the...
Então, no marca-passo,
Now,
vamos ligar
can you have the
120, por favor.
hemodynamics in the screen, please?
120, por
Have
favor.
camera
120.
and the small screen hemodynamics and large screen the angio. Great. No, not echo.
120?
Hemodynamics, please,
Ok.
if it's possible. Great. Thank you.
180.
Now we are 180. I think we are in a good position. Still at the same position, Dimitri.
Yeah.
minute, just seeing the...
180,
Okay.
vai, filma.
Now we are in
Injeta,
deploy the
injeta.
valve. Inject, please.
Injeta.
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 Tô indo aqui. Tô indo,
Injeta.
tô indo, tô indo.
Contraste.
Precisa não, precisa não.
Não, agora não.
Ok. Ok. 2,
Ok.
3, 4, 5.
So 1, 2,
Desliga o
3, 4,
marca-passo.
5. Pacemaker
Pace
off. Okay, great. We pull back. The valve is in the place. Tito, now can you see the echo in the screen, please?
Yeah.
Echo in the screen. If you can have the echo in the large screen, maybe it's a little bit better, please. Echo in the large screen. Great, thank you.
Yeah.
Ao guia.
Tito, the word is yours.
Yeah. First, we don't have pericardial effusion on our alteration of the segmental contraction. The valve seems to be in the good place. Let's see the gradients.
So no pericardial effusion, no aortic regurgitation. And now you are checking the gradient. Is that correct?
Yeah, exactly.
Okay.
The valve seems a little bit higher, but I think it's a good position for a bicuspid.
Okay. Now, what Dimitri is saying, it's the valve is a little bit higher, but I think it's a good position for a bicuspid.
Yeah,
We
our
have-
tendency now is to...
Uh,
How about the gradient?
We have a max gradient about 6.6 and a mean gradient about 3.8.
So,
great.
what do you think? Should we post dilate
No,
or?
no. I don't
It's
think
fine.
so. Is there any paravalvular leak, Tito?
No, no paravalvular leak, just some trace in the valvular regurg.
So, Fausto, we're
Nothing like
gonna
that.
exchange the wire in the left ventricle for
Okay.
a pigtail,
Uh-huh.
and then we're gonna check the gradients.
So if you have 5,
invasive
can you have
gradients.
5 more minutes?
So, and perform
Excuse
a
me.
final angio.
Hello? May we have 5 more minutes? I don't know if, are you hearing me? Can you have 5 more minutes? Okay, good. We are just finished. So we are exchanging now. If you show hands, we are exchanging now the guide wire with the pigtail, just to check the pressure by hemodynamics. We just checked with the echo. The maximal gradient was 6, and the average, the median was 3.8. So it's very acceptable result. The valve is implanted a little bit higher, but that's what we usually do in bicuspid valve. I think there's a very good teaching point. And now Alberto's bring the pigtail. We are going to show the pressure. Can you show the hemodynamics instead of the echo, please? Just to show the hemodynamics, please. Great, thank you.
20, por favor.
Yeah.
Joga pra frente aqui pra gente preparar.
So if you look at the hemodynamics, there is no gradient. Is that correct, Dimitri?
Yeah.
No gradient.
And
Yeah.
diastolic pressure
Yeah.
is above 50. So
Yeah.
even if we get a paravalvular leak, this is not hemodynamic important.
So the diastolic pressure is 50, you said? Yes, 167 over 59.
Yeah.
Is that, yeah, okay. Now what
We just insert a pigtail in the left ventricle because it does not interfere with the angio that we are going to perform.
So do you usually always do an angio?
Yes,
Okay.
unless the patient has renal failure.
So just to check,
just to check.
So I mean, interventionalists they like to see the contrast, but even though we use it just a little bit.
Injeta.
So
Injeta.
Injeta, contraste. Vamos?
No.
Não, agora espera. Vamos. Ok, we need to just. Vamos prestar atenção, por favor. Atenção. Tá pronta? Tá pronta? Então tá bom, vamos lá. Again, we are gonna move.
Injeta.
Film. Injeta. Injetou ou não?
Não.
O que aconteceu?
Let's do it again. Vai para frente, por favor. Vai para frente.
We're
Ok.
just trying to fix the
Inspira,
pump of a
inspira.
dye. Cuidado com o ar aí.
Tá aspirando?
So we
Arma
still
de
have
novo.
2 minutes just to see the
Arma
dye.
de novo, por
And
favor.
Tito is finished with the echo measures.
Arma. Arma 2020.
Okay,
Let's try again.
let's try again. Film,
No,
inject, please. Inject.
no,
Okay,
not working.
no dye. So I think we saw by
We'll do by hand.
echo. Can you have the echo again in the image, the large screen, please? And while you fix it, echo in the large screen, please. No, in the large one, please. Echo in the large, and Tito, give your. Could you please your final words, Tito, with the echo?
Yeah. Actually, we can see a very good result. We don't have any paravalvular leaks, and the gradient just reached 6 in the maximum of that. So it's a well successful
Okay,
procedure
good.
again.
Now, can you bring again the angel? Because we did a aortogram here. Now you can see that. Can you? Okay, great. And you see, there is no aortic regurgitation. The gradient is quite low.
Yeah.
What are you going to do now in the femoral access? With one proglide,
So, yeah,
can you
we're
show
gonna
that?
just closure the access.
Can you bring the camera just to finish with the Alberto hands? Just to see if it's possible to close the femoral artery with only one proglide. Please do that, Dimitri.
O dilatador para mim, Michel. Dilator, please.
Bisturi para
Tirou o
cortar o
ponto já?
ponto.
Que eu saí?
Yeah, it's off.
Now we are bringing the introduction sheet. Now we're keeping the guide wire.
Yeah, take it.
You are going to do an injection.
Yeah, in the end, we generally do,
Okay.
but I don't know if it's gonna have
Could you
time
close now? No angel, only the large screen in the hands. Great. Thank you. Thank you. A little bit closer if it's possible, just to see what he's doing. Closer, closer and closer. Great. Great technique. Yes, that's perfectly. Now we have the proglide over there, just to see.
Take off the wire.
Yeah, just some oozing here, but generally what we do now is to give some protamine and then compress for 3 minutes, and then we're gonna remove
How many
the
minutes?
wire.
How many
3
minutes?
minutes.
3
3
minutes.
minutes.
Yeah.
And then we're gonna remove the wire and perform a final angel
Okay, great.
to see if there's any complication.
Great. So can you bring the camera now for all the operators and if all the people who worked with us in this procedure? Great. Dimitri and Alberto, if you look at the camera over there, you are the star here. Alberto is our junior staff here in the cath lab. And it's important to say that I like to joke, some guys who are still in the college, not in the university, can do this procedure. But you need to so concentrate in doing well like you did. Congratulations to both of you. Also the ECHO, the anesthesiology team, and our beautiful team of nurses. Fernanda, and could you come here, please? Fernanda, please come, all of you. Renata, Reiko, all the nurses that work with us in our cath lab. Thank you, and I'll see you next week, next Wednesday, in 7.